Hello, this is a virtual microscopy slide of a leiomyoma of the esophagus, and we can see that this nodule here is in the wall rather than rising from the mucosa, and in fact it appears to be rising within the muscularis propria. Let's have a quick recap of the esophageal histology. So we can see that this is the mucosa, which is composed of non-keratinizing stratified squamous epithelium. And here is the lamina propria. Deep to this is the muscularis mucosae, which is formed from these vesicles of bland, smooth muscle cells. It is a thin layer, and then deep to this is the submucosa, and in turn, deep to that is the much thicker muscularis propria layer, and then finally we have the adventitia. This is a very well circumscribed, rounded nodule. There is no capsule, but you can see that it is very well demarcated. There is no evidence of any invasive growth into the wall of the esophagus or into the overlying mucosa. In this instance, this tumor compresses the overlying mucosa, but in some cases, it can actually cause ulceration into the overlying mucosa and then potentially GI bleeding. Zooming in, we can see that this tumor is composed of these parallel fascicles or bundles of spindle cells. The cells have abundant eosinophilic cytoplasm. The nuclei are slender and elongated, and they are relatively bland. We don't see marked nuclear pleomorphism. Looking around, we also don't see evidence of necrosis. And if we do a careful mitotic count, we should not encounter mitotic figures. So this is an example of a leiomyoma. It is a benign smooth muscle tumor arising in the wall of the esophagus. The cells of this tumor look virtually identical to the cells of the benign smooth muscle that makes up the muscularis propria. Let's learn a bit more about esophageal leiomyoma. The leiomyoma is a smooth muscle tumor, and it is the commonest benign tumor of the esophagus. It tends to arise from the inner circular muscularis propria layer. So we can see here that this is the muscle layer, the muscularis propria, which is brownish in color, and this is the rounded tumor nodule that arises from this muscularis layer. The mean age is 35 years, and there is a male predominance over females. Sometimes, in some clinical settings, the patient may have multiple leiomyomata, for example, in MEN1 syndrome or very uncommonly in Alport syndrome. In Alport syndrome, there may also be leiomyomas in the tracheobronchial tree as well as in the uterus. Clinically, these tumors most commonly arise in the mid to the distal esophagus, and they may be asymptomatic, or sometimes larger tumors can give rise to obstructive symptoms such as dysphagia, heartburn, and regurgitation. Rarely, the tumor can protrude more obviously into the mucosa, giving rise to a polypoid appearance. And this is a tumor that is benign, so it behaves in an indolent manner. There is a separate video describing the gross pathological features using this virtual pathology specimen, and this video can be found in our online free pathology resource, Pathweb. Registration is completely free, and the link is in the video description. So there is usually a very well circumscribed rounded mural mass, and this mass is in the wall of the esophagus rather than arising in the mucosa, so it tends to lift up the mucosa or bulge into the lumen, and sometimes it can give rise to a degree of ulceration in the mucosa. The cut surface has a characteristic whorled appearance, very similar to that seen in uterine leiomyomata. So here we can see this whitish cut surface with a vague whorled appearance. Microscopically, what we will see is a well-circumscribed but unencapsulated nodule, and we can see here that it actually arises in the muscularis propria layer, and the nodule is composed of these parallel bundles or fascicles of bland spindle cells. The nuclei are quite slender and elongated, and they have abundant pink or eosinophilic cytoplasm. In leiomyomas, we should not see necrosis or mitotic figures, and there is no significant nuclear pleomorphism. If these features are present, we would be thinking of malignancy. For example, a leiomyosarcoma. As we can see here, there is more obvious nuclear hyperchromasia, enlargement, pleomorphism. There are higher NC ratios, and we also have the occasional mitotic figure. Fibrosis or calcification, which are secondary degenerative changes, may sometimes be seen in leiomyoma. When we are looking at spindle cell mesenchymal tumors of the gastrointestinal tract, there are some main differentials that we would think of, including leiomyoma, and usually immunohistochemistry is very helpful in this instance. They are usually positive for Desmin and negative for the GIST markers CD117 and DOG1, and negative for S100, which is a marker for nerve sheath tumors. Gastrointestinal stromal tumor, or GIST, is the other main differential diagnosis, and this is usually positive for CD117 and DOG1. And we can see here an example of a GIST, and usually the nuclei of GISTs are much more elongated and slender, and also appear to be more crowded compared to those of leiomyoma. Schwannoma, which is less common, can look very similar, and immunohistochemistry with S100 is very helpful. In the esophagus, the commonest mesenchymal tumor would be the leiomyoma. Hence, in summary, this is a leiomyoma arising in the muscularis propria layer of the esophagus. It is protruding beneath the mucosa, and there is no overlying mucosal ulceration. This tumor is well demarcated, and it is composed of fascicles of bland spindle cells with elongated nuclei and abundant cytoplasm. There are no areas of necrosis. There is no significant nuclear pleomorphism, and no mitotic figures are identified. This is a benign neoplasm. Thank you.